Hello, my name's Corey. This is my video portion of this week's Nurse 730 assignment, and the assignment is a case study about a 76-year-old woman named Susan who is experiencing mild symptoms of neurocognitive decline in her everyday activities and functioning. So her family brought her in to be seen by her healthcare provider. And a brief description, overview of neurocognitive disorders. These are, it's an umbrella term for conditions affecting cognitive functions like memory, attention, and executive function. They are classified as either mild, which still allows independent living, which is Susan's case, and there's a major, which are symptoms that are interfering with daily independence and are caused by underlying medical diseases rather than psychiatric disorders. So these disorders typically involve damage to nerve cells in the brain. They encompass three main categories, one being delirium, a sudden temporary state of confusion and severe reduced awareness. Again, it's a temporary state. The mild neurocognitive disorder is a modest decline in cognitive function where individuals remain independent in daily tasks. And then the major one, which we talked about, which is a significant decline in cognitive abilities that impairs independence and the ability to perform basic daily activities. Some in the cognitive decline, there are neurodegenerative diseases, which are Alzheimer's, Parkinson's, Lewy body disease, and frontotemporal degeneration. There can be vascular issues such as a stroke or transient ischemic attacks, TIAs. There can be trauma, so this would be a traumatic brain injury from a blow to the head. Metabolic and systemic conditions, so that could involve vitamin B12 deficiency, thyroid disorders, or chronic liver and kidney disease, and also substance abuse, so long-term alcohol and drug abuse or medication side effects. In our scenario with Susan, we have that she's come back. The patient's acute worsening of symptoms is happening, and they're wondering why, our family's wondering why, and that would indicate a potential delirium superimposed on dementia or an adverse drug reaction. So what would the next steps be? These immediate next steps would include a comprehensive physical and neurological assessment, a thorough medication review, checking for drug-induced delirium, and screening for any underlying infections or metabolic derangements. So what would a medical diagnosis rule out? Infections, especially a UTI, urinary tract infection, or pneumonia, which can frequently present atypically as acute confusion in older adults. Also metabolic electrolyte imbalances, so that would be dehydration, hyponatremia, hypoglycemia, or renal hepatic dysfunction, which can cause confusion and neurocognitive deficits. Also neurological events such as TIAs, stroke, or seizures, cardiovascular issues, so a myocardial infarction or arrhythmias that can cause cerebral hypoxia, and then any other contributing factors such as uncontrolled pain, fecal impaction, or acute sleep deprivation. So what do the medications rule out once we're looking at the medications? I did suggest that she go on Aricept or donepezil, and while it is the standard for dementia, especially in the mild phases, um, acetylcholinesterase inhibitors can rarely cause or worsen neuropsychiatric symptoms like hallucinations. So it's probably not that. So then we would maybe look at, it's called the Beers criteria consideration. So we look at other medications that can be strongly linked to acute confusion and delirium in older adults. So that would be first generation antihistamines like Benadryl, benzodiazepines, tricyclic antidepressants, certain sleep aids, and anticholinergics, especially for oxybutynin, which is overactive bladder medication. Some items that I could discuss with the family and caretakers about their education in Susan's condition. I would definitely go into defining delirium versus dementia. So I would educate the families that this acute change is likely delirium, which is a sudden fluctuating state of confusion rather than a rapid progression of dementia itself. So this is an acute phase, and finding the underlying cause is what's going to stop it. So definitely talking to them about safety being first, teaching them how to create a calm, quiet, and well-lit environment to reduce nighttime hallucinations, ensure that the familiar objects and clocks are nearby to maintain Susan's orientation, and then teaching the family what any red flags would entail. So when to seek medical attention, such as fevers, fall, refusal to eat or drink. So as far as effectively balancing my clinical judgment versus patient-centered care, there are considerations such as medication adherence challenges, cognitive deficits, patient insight, and shared decision making. So medication adherence in patients with cognitive deficits, the patient must rely on caretakers and blister packs or daily check-ins for adherence, also including the shared decision making with the patient, because the patient insight and capacity to make complex medical decisions tends to break down as the dementia progresses. The focus shifts towards substituted judgment, so maybe what the patient would have wanted, and supporting the family caregiver as the proxy in this scenario. How have my beliefs, biases, and empathy about neurocognitive disorders changed after learning about the neurobiology of this disorder? So for me, this has been very interesting. I don't have a great deal of experience with neurocognitive disorders, and so what I do have as a bias isn't necessarily from direct experience with family members or patients, but now that I know more about why neurocognitive disorders are happening on a neurobiologic level, it does foster more patience that I can have with the patients, shifting the narrative of dementia as, you know, a difficult behavior to actual biological neurodegeneration. For example, with Alzheimer's, it's actually the amyloid plaques, neurofibrillary tangles, and neurotransmitter loss that's causing it. So they are biological, physical conditions that are happening. So, so this does fundamentally, for me, increase my patience and empathy for the family and patient. It also helps me to recognize that challenging symptoms like resistance or hallucinations are manifestations of a diseased brain, not intentional actions. So, also, the clinical knowledge behind it does bring hope, because there is new research, there are medications that are improving, and it brings the hope of the quality of life to improve for these patients. Excuse me, I'm going to sneeze. It shifts the expectation from a total cure to, just a sec. Pardon me. Because I'm so far along in this, I'm not going to turn around and go back and redo it. But it definitely shifts the expectation from a total cure to maximizing the patient's function, optimizing the environment so that the patient can thrive, and easing the burden on caregivers with support. So, in what ways do my feelings about risks, side effects, or complexities of the medication shape the way I discuss treatments? So, recognizing that drugs like antipsychotics or anticholinergics carry high risks, especially with increased risk of stroke or death. Can make prescribers, and rightfully so, highly cautious. So, to avoid unintentionally removing autonomy from the patient, clinicians must still involve the patient in decision making, in small daily choices to the extent that they're able, ensuring that even nonverbal cues or expressions of discomfort are valued. So, being cautious with prescribing and yet still involving the patient in the process is the balance there that I would be shooting for. And then when patients struggle with adherence, common emotional reactions can include frustrations or feeling of futility, which is probably normal for the caregiver to be feeling. However, again, once understanding the neurobiological reasons why the patient is acting this way, it changes how we approach these patients and help them. So it's really alignment of these principles in order to have more empathy and patience. This guides the clinician to shift the responsibility to taking care of the patient and not blaming the patient. So anyway, those are my thoughts on this wonderful homework assignment that we had. I learned so much, and I will see you next time. Thank you.